When a diagnosis of nephrolithiasis is clinically suspected, imaging of the kidneys, ureters, and bladder should be performed to confirm the presence of a stone and assess for signs of urinary obstruction, i.e. hydronephrosis. If a ureteral stone is suspected or detected, stone size and location are used to predict the likelihood of spontaneous passage and to guide management. Ordering the so-called KUB, or abdominal radiography, does not detect hydronephrosis and is less accurate than CT for stone detection and localization. The exam enables stone size measurements and is most often used either alone or in combination with ultrasound to follow patients being managed for kidney stones. Large radiopaque stones such as calcium, struvite, and cystine stones are seen. However, uric acid stones, as well as smaller stones, which are radiolucent on abdominal plane radiography, are often missed. Ultrasound of the kidneys and bladder reliably detects hydronephrosis and does not involve ionizing radiation. Ultrasound is less accurate and demonstrates greater user variability than CT, however, of the abdomen and pelvis without contrast for the diagnosis of nephrolithiasis. CT of the abdomen and pelvis without contrast performed using low radiation dose protocols is the preferred exam for most adults with suspected nephrolithiasis. Contrast is usually not administered because it decreases the sensitivity for smaller stones, and for stones greater than 3 millimeters, the sensitivity of detection between the two modalities is comparable, so spare the kidneys. Another advantage of the CT modality is that the appearance, density, and location of a stone may suggest its composition. If CT technology is not available, ultrasound of the kidneys and bladder, sometimes in combination with abdominopelvic radiography, is the second-line option for initial imaging. Women who could potentially be pregnant, meaning all of childbearing age, should undergo screening for pregnancy, i.e. a urine or serum pregnancy test before CT, or even the abdominal radiography. If the patient is pregnant, an ultrasound is the preferred modality. Acute therapy should focus on 4 things. 1. Straining the urine. 2. Pain control. 3. Stone passage. And 4. A urologic consult. Most patients with acute renal colic can be managed conservatively with pain medication and hydration until the stone passes. NSAIDs appear to be at least as effective as opiates. NSAIDs have the possible advantage of decreasing ureteral smooth muscle tone, thereby directly treating the mechanism by which pain is thought to occur, the ureteral spasm. Urgent urologic consultation is warranted in patients with urosepsis, acute kidney injury, anuria, and/or unyielding pain, nausea, or vomiting. Stone size is the major determinant of the likelihood of spontaneous stone passage, although stone location is also important. Most stones less than or equal to 5 millimeters in diameter pass spontaneously, whereas the spontaneous passage is unlikely with stones greater than or equal to 10 millimeters in diameter. Proximal ureteral stones are also less likely to pass spontaneously. Both tamsulosin or Flomax and nifedipine have been shown to increase the likelihood of stone passage, with Flomax showing slightly better results. Patients should be instructed to strain their urine for several days and bring in any stone that passes for analysis. This will enable the clinician to better plan preventative therapy. Urgent decompression of the collecting system with either percutaneous drainage or ureteral stenting is indicated in septic patients with obstructing stones, bilateral obstruction with acute kidney injury, and unilateral obstruction with acute kidney injury in a solitary kidney.